Today, you'll hear from Dr. Susan Kressley, a general pediatrician with over 30 years of clinical experience. And she's also the medical director at Office Practicum. She is a health IT industry thought leader and involved in several relevant initiatives at the American Academy of Pediatrics and a national multi-stakeholder work group focused on protecting privacy to promote interoperability. With that, it gives me great pleasure to introduce you to Dr. Kressley.
Thanks, Carrie, and thanks everyone for taking time out of your busy summer schedule to join us on this important topic, Closing the Loop on Care, the first of our two-part series on improving clinical and financial outcomes. I'm going to turn off my webcam so that you can have your full attention to the slides. But again, thank you for joining us. So our learning objectives for today are recognizing that providing great care requires more than just office visits. And we're going to describe the importance of implementing workflows that are proactive, not just reactive. Boil those down to two very important loops that we should close on a regular basis, and that is implementing a complete referral management process, as well as a comprehensive diagnostic test management process. And then let's talk about the importance of an empowered practice team. I first want to point out that practicing great medicine is good business. And so while we're going to talk about clinical outcomes here, to me, the good medicine and business go hand in hand. We've spent the last year, 18 months, especially through the public health emergency, really understanding that we need to identify and close care gaps. That includes patients who are due and overdue for well visit, as well as chronic disease management. We've done a lot of work around recalling our patients, and there are those who missed care over the last year that we are working hard this summer to close again. Not only does closing care gaps add additional revenue to your practice, but it improves your quality metrics and any pay for performance incentive payments that you may have from your payers. But it's not just about bringing those patients in for care. The other loops that should be closed regarding clinical care also have implications for your business. Managing the referral loops is essential for care coordination so that patients and families have all of the care they need wherever they should best receive it. And it helps us to understand the total cost of care and improves and it enables us to manage that total cost of care. And we'll get to that in a minute. Managing the diagnostic test status also ensures that your patients follow through with your agreed upon treatment plans. It's one thing for us to talk to a patient or put in our note that we order something, but if the patient doesn't follow through with it, we have no idea what the impact is to their clinical care. When we manage the diagnostic test status, it emphasizes to our patients and families that we not only are providing care to them, we care about them. This is important. Let's talk about why ordering these tests is important for your treatment plan. And we also know that managing that status reduces delays in diagnosis and makes sure that patients get the most appropriate care. It also can improve the total cost of care in that we have the answers when we need them and we don't have worsening care or patients seeking care outside our medical home. So many of you are tired of hearing me talk about the total cost of care and some people are still struggling, what's the relevance to their practice? So you should know that total cost of care is the care it costs for that patient no matter where they go in the healthcare system. And that's not just the care that you provide, but if you are the primary care physician of record, all of that money that is spent outside your office and inside your office is being attributed to you. And whether you are tracking this or not, payers are collecting this data on your patient population and how much they cost seeking care wherever they go in the healthcare system, to a lab, to a health system, to a hospital, to a specialist. They are collecting that data, and then they are using this information to decide who's a valuable pediatrician and primary care person to keep in their network. And if you are good shepherd of the healthcare dollars, they will decide to incentivize you to stay in their network, and sometimes even give patients incentives to see you at a lower cost, a lower copay than some of your competitors. If you have exorbitant fees for all of your patients, they are more likely, when they narrow their networks, deciding that you are no longer worth keeping in their network, and they may drop you and can do so with very little notice. So we should be spending our healthcare dollars as if it was our own money, because for our patients, it often is. And I would urge you to understand that it is important for you to know how much the labs and specialists that you refer to are contributing to the total cost of care. So is this some test that you would spend your own money to pay for? Is this a specialist who orders tests and procedures that are in keeping with what you think are the best return on investment? It's important for you to understand that no matter where your patients go, you have an influence in their total cost of care, and that influences your leverage with payers in your networks. So there is so much to do every day when you're seeing patients in front of you. It's often easy to forget about the patients you can't see. And I'm going to urge us during this hour to change your care lens to not seeing what's in front of you, but going to a higher plane and understanding what the implications are of the things and the care for your patient population that is not immediately in front of you and visible to you. So I'd ask you to consider, for example, the 3-week-old that you have that has a murmur, and you are worried about this child's murmur. What happens to that patient who never makes it to the cardiologist you referred them to? Do they ultimately end up in the ER in extreme heart failure because they didn't understand the importance of the referral? It cost them too much where you referred them. They called for an appointment and were put on hold and hung up. All of those things that you order, and when the patient then leaves your office, if it's not visible to you, there can be clinical harm to patients. And if you talk to your malpractice carrier, they will tell you that treatment plans that you order but you don't proactively follow up with are one of their biggest risks. And many malpractice carriers actually have closing the loop CME modules that you can take and often get a discount in your medical malpractice. So I urge you to reach out to your malpractice carrier and ask them if they have any medical education that you can do to extend this conversation to every provider in your team. What happens to the patient with abdominal pain who you order a CBC, a celiac, a SED rate, a CRP, et cetera, and for some reason they just never make it to the lab? It could be that they're from a 2-working parent household and they just can't get there. They're essential workers when the lab is open. So what happens if they never get that lab work done and all of a sudden they end up in the emergency room by ambulance because they passed out with a hemoglobin of 6? And it's because they had significant inflammatory bowel disease and flared, and you may have been able to prevent that sad scenario from happening. It happens all the time. And what is our role in making sure that patients that are trusting us for care, what is our role in that? And I would argue that it is in combination with the patients and families. But while we live in the world of healthcare and we think it is the most important thing in our day because we live in it, that is not true for a family who's got competing priorities of a job they have to keep, bills they have to pay, housing problems they're having, food insecurity, et cetera. And so while we think it's the most important thing, it is not always the highest priority to our patients, and we owe it to them to partner with them to make sure these care loops get closed. Managing your patients is a team sport. Remember, this is not all the providers' work, and I hope that people are joining me from the practice team because you're probably going to have to figure out how you get your providers and your pediatricians to prioritize this work. But not all of the proactive follow-up. We're talking today about proactively identifying the information, not just waiting for it to show up in your inbox. It does not need to be done all by the clinician who orders the treatment plan, and I would argue it's not the most effective use of our time. But In order to fully manage patient care, including what's happening that's not immediately visible to you, it takes people on the team who understand the importance, processes, and backup processes, because we all know that occasionally technology fails and people are out on vacations or illness emergencies, and you need to have a backup process for your process. And then you want to have appropriate technology to support this work. I would encourage you to remember that if it's important enough to add a diagnostic test or referral to a patient's treatment plan, it's important enough to make sure that there's appropriate follow-through. So we're going to start by taking a deeper dive into referrals. And we're going to talk a little bit about the referral process and closing the loop, but it really starts with deciding to make a referral. And how do you go about that in your practice? Normally, we like to say, start with, does this patient need care that is outside my expertise? Is this something that I just don't have the expertise to manage or diagnose? And then, do I refer this patient and family to a specific group or a specific person, specialist, or do we give the patients a choice? And some of that probably makes a difference depending on what the problem is. And sometimes it's a insurance-driven covered provider choice. And then what do we do about the patients who want to self-refer? They have a mole that you know is benign, but they need to see the dermatologist. How do we manage that, and how do we manage that in the referral process? And then the second step to the referral process, after we've made that decision to refer, or the patient self-referred, that care coordination is critical to making sure the patient gets appropriate care. And that starts with tracking the referral. It's assessing the specialty access to care and setting appropriate expectations. We know that if we have children who we suspect a development delay or maybe on the autistic spectrum disorder, that they're not going to get into the developmental pediatrician of your choice in 2 weeks. So how do we both understand the specialty access, and how do we set the appropriate expectations for the patients and families and our clinical team? And then part of that is providing both the patient and the specialist appropriate clinical information. We know we hate it when the babysitter comes in and we say, why are you here today? And the babysitter says, I don't know, I was told to bring the child for a visit. Our specialty colleagues also don't like it when they have a patient in front of them who doesn't really know why they're there and they're trying to figure it out. So let's make sure that we all have the appropriate clinical information to have good care. So why should we track these referrals? It was very interesting. Over a decade ago, my practice started the process of patient-centered medical home recognition. And NCQA PCMH is not the only reason to do this work. Every patient and every family deserves a pediatrician who is proactively engaged with them and managing their clinical care. But we discovered when we were referring for patients to care, a third of them never went. And so the question we had to ask ourselves is why? And are you looking at why? Some of it is the families didn't know why it was important. Some of it is their out-of-pocket costs were too high. Some of it is that they tried to get an appointment and they couldn't. But if a third of people we recommend to care don't go, what is the implication for that patient's care? And then a third of the patients that we were tracking went, but we didn't get a report back from the specialist. And in some cases that may be higher depending on your specialist network. And then how often do your patients actually follow through with the specialist recommendations? If the specialist orders additional lab work testing, do they understand that recommendations? Are there barriers to follow through? Including inconvenience, not understanding the importance, cost, insurance coverage, all of those things. So while it may not seem like this is our fault, it is essentially our problem, and we should be partnering with our patients and families to understand what happens with the specialist's recommendations. And then we should be really looking at those treatment regimens our specialists are making so that we are in alignment and we communicate this to families. So I think about my allergist friend who I kept seeing for mild asthma. The patients were being recalled every 3 months. And I was like, I don't think you need to see my mild intermittent or mild persistent asthmatics every 3 months. How come you keep recalling them every 3 months? And their answer was, well, our EHR template says they should come back every 3 months. And so the answer was, I have conversations with those families and say, I can take over from here. They did some allergy testing. We know what your triggers are. They're going to keep sending you an every 3-month reminder. But I don't think it's necessary for you to go add the additional inconvenience. We'll handle your problem here in your medical home. And if we need to refer back, we will. And then you also want to know, are they recommending high cost procedures and medications? If every patient you refer to the GI specialist is getting an endoscopy and a colonoscopy, you have to say to yourself, am I not referring enough patients, or are they doing this for some other reason? Does everyone get expensive medications when you know there are lower cost alternatives? For example, a talking epinephrine autoinjector. You need to be looking at, when you get reports back, are they again spending that money as if it were their own with the total cost of care in mind? And if not, do you have conversations with them? So this is a closing the loop on referrals, and I will put the picture in the middle on purpose. We have to remember to keep the patient and family at the middle of this loop. This is not about us. It's about partnering with families and kids so that everybody is getting the right care. And so let's start about that decision to refer, which we talked a little bit about, and we'll get into a little more deeper. We know that even in your own practice, you have very variable differences in who gets referred for what. And that is a place that we will spend some attention in the next slides. But starting after we refer, the care coordination is entering the referral tracking process. And that's to make sure that the patient actually visits the specialists. And if the patient is going to the specialist, we owe it to them to transfer information to them, both the reason for the referral and any pertinent labs to date, growth charts, visit notes, etc. The specialist visit then occurs, and we hope that then the specialist transfers information to us so we understand additional testing and plan of care. And if this loop doesn't happen, we need to go back to that specialist and make sure we get that information to proceed to the next part of care coordination, which is both information reconciliation, that's taking that information that came back from the specialist and reconcile the patient's information in our chart, and then truly integrating care. That means looking for duplicate medications. Did you have the patient on one controller medication for asthma and the specialist is changing it? You want to know, the patient needs to know which one they're discontinuing and which one they're continuing. And then who's responsible for that ongoing care? And there really has to be a part about understanding and acceptance of a new shared plan and make sure that it's communicated to the families. You can't expect that they understood everything that happened in the specialist. We have to affirm it. And the reason this loops back to decision to refer is, what if this is a patient who you have an unknown diagnosis and you send them to one specialist and they're like, yeah, it's not cardiac, Sue. I don't know why this patient is having chest pain. The question is, do you have a new decision to refer? And how do you make sure that you make this loop keep closing? Or it's a patient who goes back every 6 months to see the specialist. And how do you make sure that loop keeps closing? So let's talk about implementing that referral management process, which again starts with the decision to referral. There are some studies and there's some resources at the end of these slides where in the same practice, there are providers and clinicians who refer 5 times more often than their colleagues in the same practice. Do you even know how often each of your providers is referring to specialists? Do you know for what problems? And do you know for how often that's happening? There's probably a lot of variability in your practice's subject matter expertise, but you really want to make sure that everyone's on the same page and decide as a practice team, what are we keeping in our medical home and what can we send out? And you want to do that because it creates uniform expectations from families. If your partner sends everyone with an innocent murmur to cardiology after getting an EKG and a chest x-ray, and they have a new baby and you know this is an innocent murmur and you don't do the same thing, they are going to think that you're not as good a provider because you didn't do all of those extra tests to be careful. You want to make sure that you're setting uniform expectations from your families about how you deal with problems that are common in your practice. And you also want to create uniform expectations from your practice team, because they get confused when one clinician does it one way and the other two do it a different way. You want to make sure that you're aligned. I look at this akin to some of your clinicians liking to give an MMR at 12 months and some of your clinicians liking to give it at 15 months and some at 18 months. You're going to make mistakes. Parents are not going to know what to expect. They're going to have unexpected or have unaligned expectations of what good care looks like. You want to make sure that your practice team is aligned. Who do we refer out for what problems and where? There is less opportunity for mistakes and unclosed care gaps if you're all aligned, and you can utilize the subject matter expertise within your office team. I happened for some reason to end up with all of the teenage patients with eating disorders in my practice, but I like to do it, and the patients seem receptive to me. And so my office team would often sort of send patients with those presenting problems my way in my schedule instead of some of my partners who were not as comfortable. Or if it was happened to see a patient that was that they were uncomfortable with, instead of referring them immediately out, they would say, let me talk to my partner and we'll get back to you with a plan of care and engage that and hand off to a partner in your own team. And you may actually use your clinical nurse specialists or your team to follow up on some of this so it doesn't have to be all you. And then you want to maintain a repository of frequently used specialists, especially if you have big networks or people coming and going. That should be something that's updated on a regular basis so that your office team, if somebody's calling in and say, hey, I couldn't get an appointment with the ENT with 2 weeks out that you gave me, are there other names that I can use? You want to have your whole team not having to come back to you to ask you that question. You want to maintain a repository of frequently used specialists. And then you want to, when you give that referral to the patient, and this is incumbent upon the clinician who decides the patient should be referred, you want to impress upon them the importance and reason for the referral and level of urgency. You want to talk to them about reasonable expectation and how long it's okay to wait for an appointment. And for that 3-week-old who had a murmur, I would have said to that patient, I want your child seen within the next week. If you can't get an appointment, I want you to call back, ask to speak to Colleen at the front desk, and she will get you squeezed in. This cannot wait. I think it's okay, but I am worried at this age group that your child, if there's something significant, we need to know it now so we can be proactive and get you into appropriate care. And I would consider, wherever possible, for that 3-week-old, I probably wouldn't have let that mom call to make an appointment. I would have had Colleen call and get that patient a handout and give them a worn handout. You're going to see Dr. Stevens. Here's the address. Here's the information to take with you so that you're sure that the patient had a higher likelihood of making it to that appointment, which you thought was so important for clinical care. So let's talk about getting that information to the specialist. And the content should be at least the reason that you're sending the patient. And sometimes that is feel patient growing well, symptoms of infant reflux, but mother just wanted a reassurance there was nothing more significant. If you say that to a specialist, they're going to read between the lines and say, oh, like Sue's not really worried and doesn't think this kid needs an endoscopy. This mother just needs to know that she was giving good advice. But you also want to give them important information. Growth charts are important for pediatrics, and a lot of things that we send to specialists, any labs that you may have already done, and clearly any pertinent notes to date. It is way easier for them to be able to act correctly if they have more information than trying to figure out why exactly that patient's in front of them. And I think the way that you get the information to the specialist, or the manner, there should be no wrong door to having the right information. And that can include direct messaging with a CDA and other documentation, sending directly to the specialist, faxing it to the specialists, giving families a physical copy, telling families where they can find it on the portal if they get to the specialists and they can't see it. And I recently had a colleague say to me, so Sue, like, why do I hand family a physical copy if I'm going to fax it or direct messaging it? Well, we've all had this experience. It depends on how the mail gets sorted in the specialist office. I know that if I text or email my colleague directly, it's getting there. But I also know that if I'm sending it to, quote, the inbox at Children's Hospital of X, that it may take a week or two to wind its way to the appropriate ENT department. And then what if the ENT had to cover for somebody else out that day and it's not in front of them? I always say to families, look, I'm going to try to send this a different way, but you may end up there, and I don't want the specialist to say, I don't know where this information is, it got misfiled. Have it with you, have your portal access, or have your physical copy so that we can most appropriately equip the specialist with all the right information to give you the best care possible. And then timeliness matters, right? If you're sending that patient with a murmur to be seen within a week, and you hand this to your medical records people and she's out on vacation, it's going in 2 weeks, that doesn't help, right? You want to make sure that you have timeliness of transfer of information, and it prevents frustrations both on the families who say, I don't know why my pediatrician was so worried about this, and the specialist doesn't either, and they sit there and look at each other and wonder why the visit didn't happen. You look smarter and you look like you care if you give the right information to both the specialists and the family as part of that referral process. So let's talk about tracking that referral. You should set a tracking date on when you expect to get a report back from the specialist. If you just are your team is working through the backlog of reports, you can get very lost in the weeds. If it is a patient that I'm sending to the dermatologists and I say, all right, within the next 6 months, don't even put that as a flag until 6 months from now. And quite frankly, not every referral has to be tracked. You're going to get some information from patients who self-refer to the dermatologist anyway, and you wonder, why did this patient go? And that's a good opportunity to educate them. But if you think that a patient doesn't really need to go to the dermatologist for their acne, and you say to them, look, I think we can manage this, and the mom says, but my older daughter wanted to see the dermatologist. If you think that it's not critical, not every referral has to enter your tracking process. If you think it's something that you would not necessarily have to refer, there may be nuances to that if you have to track for capitated reasons and give a patient referral. But remember, not everything needs to have the same amount of criticality. If you have a way, I would mark critical referrals differently. That 3-week-old, and sometimes it's as a matter of putting a placeholder or a message or note to self to check in a week to see if that got back, or to reach out to the family to make sure it happens. But critical referrals should be treated differently than self-referrals. And then you want to have someone in your practice team who owns this process, right? You have to have an owner for the referral tracking process, someone who understands how important this is to patients and families, and then you have to give them adequate protected time to do this work. If they're supposed to do it in between putting patients back and giving vaccines, Things are going to get lost. When you're working through a process, you need protected time to do it. And you want them to run reports and say, okay, which outstanding referrals are past their flag date, and I need to work this list. I would recommend the first place you work that list is with the family. Did you actually go? And if the family says, yeah, no, find out why. It could be that the kid got better and they didn't think they need to, and then you can just close that loop there and just say, please reach out to us if this recurs. But you also, if they did go, you want to get the date and get what did you learn, what did you think, and then have some methods to reach out to the specialists by fax, phone, emails to make sure that you are closing that loop from the specialist if they saw the patient. There are some external systems from specialists who, if the specialist doesn't finalize the note, it doesn't trigger a report to you. And just like their primary care docs who don't finalize their notes, there are specialty care docs who don't finalize their notes. You need to find out what that process is. In my practice, we had an escalated series of, started with phone calls and then went to faxes. And the first one said, you know, we're sure you meant to send us this report. We expect it by the end of the week. The second one said, come on, we're worried about clinical care. Please share with us this information. We have a shared appointment, or we have a shared care for this patient, and we need to understand that they understand their care plan. And the third letter basically said, if you want us to keep referring patients to you, you have to find a way to get the information back to us after you see them so that we can be coordinators of their care. So let's talk about information reconciliation. Whose responsibility is this? So you can certainly start with someone on the clinical care team bringing back reports, but ultimately it's the responsibility of either the clinician who referred, or if they're out of the office, a covering clinician, because we're the people who can say, okay, we're replacing this medication with this medication, or that problem list item on the electronic health record, which says, you know, non-specific abdominal pain, I now have a more definitive diagnosis of celiac disease. And that information may come back to you by paper, fax, again, direct messaging with a CDA, but you should look at what's possible, what's actually happening in your office, and then work that list. You're going to both want to update the patient's chart and records in your electronic health record or on paper. You want to make sure there's not duplication. You don't want to have 3 things on the problem list, one that says non-specific abdominal pain, one that says epigastric abdominal pain, and the other one that says celiac disease, if really those first 2 were just before the patient got a definitive diagnosis, and that's called harmonizing reconciled data. And you also want to do the same thing with medications. Beyond just reconciling information, there's actually integrating the care. You want to add medications there as reference information if the specialist started some new information. You want to add some outside labs. And you may even want to say, hey, this specialist, let me add them to the patient's care network so that I have an easier way to access that team, or say to the parent, hey, it looks like you saw this allergist in the past. You're having a flare. Let me reach out to them. But you also want to look for inconsistencies between your treatment recommendations and those from the specialist, because that may cause confusions for the family. And you want to look for the specialists where they say they want to follow up with the patient and as those expectations every 3 months, or PRN, et cetera. But you want to then clarify any complex or confusing questions with the family. And it may be your care coordinator who, if there's anything questionable, reaches out to that family and says, hey, we got the report back from the specialist. I want to make sure that we are on the same page. You might be able to do that through a portal message, a phone call. There are multiple ways to get that information, but it should be shared and the family should have an opportunity to ask questions. And then you should be evaluating those people you refer to. Do those reports come back timely, and are they actually informative? Are they following reasonable evidence-based guidelines, or is it somebody who's telling your patients not to get vaccines? Is the care cost effective, or are they not even paying attention? And there's some really great innovative practice who've started to collect specialist information by posting a post-referral family survey and asking families questions like, how easy was it for you to make an appointment? Did they treat you with professionalism? How likely would you recommend the specialist to a friend? You can actually get more information about your specialists who you are using and referring your patients to by asking the families how that experience went. All right, we're going to switch gears and go to diagnostic tests. Guess what, guys? It starts with the decision to order once again. And again, I bet you will be all over the place in your practice about what tests you're ordering, but you should keep in mind and have some uniformity again, so the families have appropriate expectations, and so does your office team. We know in some studies that there were millions of dollars spent on vitamin D levels, which can cause a couple $100s to a patient who has out-of-pocket expenses. Is that really the right test to order for a teenager who has fatigue? Or is there something different that should be ordered? But if your test is worth ordering, it's worth tracking. And you should make sure that, again, after you order that test, that the tracking process is entered to make sure that the patient gets the test done, documenting why the test is being done, and so that you have appropriate follow-up. You want to, again, make sure it gets performed. If it doesn't, why not? And then you want to make sure that you get the results. If you didn't get the results, you need to feed back to the loop to find out why. And then again, there's care coordination, sharing the results with patient and family, and updating treatment plans. And yes, back to decision to ordering another test. If the patient has anemia, you may be ordering a different hemoglobin electrophoresis or additional studies to find out why. Making that decision to order tests, you should first ask yourself, is this part of routine screening? Do I need this to arrive at a diagnosis? Is this needed as part of chronic care management or acute care follow-up? And think about, there are measures for quality around hemoglobin A1C testing for patients with diabetes, et cetera. You also want to think about what about the patient who wants tests, but you don't think you need them? What is your responsibility for talking about why a test is needed or not needed? And then you need to think also about what is the best place to have the test performed. And this isn't just lab testing, I'm talking radiology. You should also consider the cost and convenience. So for example, point of care testing is most likely to be done, right? If you order the hemoglobin in-house and it's done in-house, it will get done. You can close the loop on care much faster. However, we know that some payers are not covering your costs for point of care testing, and you have to consider that in what testing you do in-house. If it's something that you really want to have done, but you don't do it in-house, you have a better chance of actually getting the result if you at least draw the blood in-house or you perform the urine specimen collection, et cetera. And so all of those things should be considered when you're making the decision to order the tests. And then, do they need pediatric expertise? Is this a hip ultrasound that you only want to do at one of your local hospitals because there's a pediatric ultrasonographer, radiologist who understands how to diagnose developmental dysplasia of the hip in young children, that is not available at an outside facility? And for those of you who don't know what the facility fee is, or your team doesn't, you should learn it. If you are doing a test that's part of a hospital system, there is often an onerous facility fee that is tacked on, and if your patients have high deductibles, or that can be cost them so much that they actually leave without getting the test performed. Make sure, just like you did with your referrals, that the patient understands why you're doing the test and the importance of the timing. I need this back within the next 2 weeks, because you want to explain and think out loud so they understand the importance. If it's important enough to order, it's important enough to discuss with the family. Tracking your orders and results. You should track them as well. It's also, again, if it's important enough to order, it's important enough to track. You want to put somewhere in your note so that if you're on vacation and I'm covering for you and this comes back or the patient gets worse, I want to know what you were thinking. Ordering a CBC and throat culture, if patient not better by end of week, would consider adding on an EBV titers for mono. Think out loud so that I understand as a covering physician, and you understand if you go back to your note after you saw 30 patients a day for 4 days, what you were thinking. Set the appropriate flag date, a culture you expect back in a couple of days. If it's a routine lipid profile for a teen, you may give them 6 months to get them back to you, but you want to set an appropriate flag date. And then when the result isn't back in the expected time, you got to find out, was it done? If not, find out why. Again, reiterate the importance. And there may be things, for example, in my practice, if you don't do a lipid profile the first time, we don't spend a lot of time chasing those down. We just note it, and the next year we say, hey, you didn't get your lipids done. This is important and why you should do it. But you want to document all those touch points in the medical record and then reset a flag date. If you've decided the parent is now going to get it done in the next week, set your flag date so you can look for it when you're expecting the result to come back. When the result is not back in expected time and the family confirms, yeah, I had that done, I had that hip ultrasound done, I had that ultrasound of my abdominal ultrasound done, you need to figure out what happened to the result. You should reach out to the testing site and get experts, say, fax me the results. And then you want to not just automatically say, well, we never get results from that place. You want to find out why. Sometimes it's because it went to one of your colleagues who's your new partner, their old address, because the lab has the former practice they worked for, and it went to the wrong place. Sometimes technology fails. There's a gap in an interface or a failure. The lab updated an interface and it broke something on your end. But if you're not tracking the results and looking for things you're expecting, you won't even know that that's broken. And then there may be process gaps or weaknesses in your own way that you handle things. And they're sitting on somebody's desk in an inbox that's on paper, that's on vacation and isn't expected back because of maternity leave. So find out why things got lost. And then you want to document your process, right? How do you get this done? You likely get results, especially from labs and radiology and other places you get diagnostic tests. You probably get some of it faxed, some of it lab results integration, some of it may be coming from direct messaging, some of it may be coming via mail. You actually want to document what your process looks like, and you may decide that you want to process normal and abnormal labs differently. That's okay. But ideally, you want the ordering provider to review the results because it may change what that clinician wants to do, and you have to have a provision for out-of-office clinicians. It's not good enough to say, oh, they'll be back in 2 weeks from vacation. Somebody needs to have, and it should be documented, because if you wait for someone to volunteer to cover their colleague, it's not going to happen. There has to be an assignment. Maybe it's every night the last doctor who's on call has to look at the inbox for the out-of-office clinicians. Identify gaps in your processes, and then use your team to say what's working, what's not working, and improve your workflows. And then you want to share your results with your patients and families. I would say when you order the test, make sure that you're setting appropriate expectations. Hey, this is a clean catch urine. You're likely to see a couple of abnormal results in there. I promise I'll call you if it's significant, but we know that there's no way to get a completely sterile void in a toddler you're trying to get a clean catch urine culture on. And be mindful of the 21st Century Cures Act, which says that patients should have access to their information. And you should not be withholding lab results for an extended period of time. Remember that the Quests and LabCorps of the world are automatically giving patients access to their lab results. You want to be the trusted source of information, and you want to make sure you share the results with patients and families in a timely manner. Make sure you update your plan of care. Make sure there's a clearly identified handoff. If it's, this looks normal to me, these are ordered short stature labs, I'm not sure what my partner was thinking, but it's not urgent. Make sure that if I'm handing this off to my partner, I have a process where she's expecting, hey, I looked at the labs, they're normal. I'm not sure what you wanted to do with this patient's short stature. It's not in your note. Make sure that that is documented and everybody understands the next steps. And ideally, it's written in your notes so that if you're not there, I can make sure I know what I'm doing. So where do you start? Drowning from all of these years of labs, referrals that you've never proactively tracked is daunting. And so there may be ways that you can say, all right, I got to clear the decks. I know I haven't been doing this for the last decade. I need to start now, but I can't do it in looking at the thousands of things that are unprocessed. You'll never stick with a process if you feel like it's impossible to succeed. So create your office team, crowdsource your current office workflow. I bet if you ask 3 different front desk and 3 different clinical staff members how you do your diagnostic tests workflow, you're going to get 6 different answers. Make sure you document them all and then harmonize and work with the team to figure out where you want to get to for your ideal workflow, and then figure out here's where we are now, there's our ideal, how do we get there iteratively, and we can get there so that patients get better care. You absolutely want to empower your team. You should get buy-in for your agreed upon workflows, and it's not just your clinicians who order tests, it's the rest of the office team who's doing this work. If you have outliers, and I'm sure most of us do, you have to agree on consistent ways you're going to document this and communicate this. We need to have everybody on the same page to make sure patients get good care and things don't get missed. Consider streamlining or simplifying your workflows. If you have too many handoffs, you are more likely to have things get lost. And after you've decided how it should work, post it somewhere. So when somebody says, how are we supposed to? The answer is, look at the workflow. This is what you're supposed to do next. Make sure you have that coverage for clinical care teams that are out of the office, including your referral coordinator, not just the ordering clinician. And then you got to monitor this work. This isn't a turning on the switch and you're done. This is, hey guys, we're doing better. We're falling behind on this. We got to find a better way to track those lipid profiles because there's gazillions of them. And is it important enough to track? And then you work out your barriers together. Anyone from your office team can propose an idea. This should not be top down. This should be everybody who's important to this work. And it should be a continuous project. This work will not be done. You will continually improve and use ideas from your entire practice team to make it work better together. Lots of good resources for you, and I believe we've got some time for questions. Thanks so much for spending the time.
Wow, that was amazing. Thank you so much, Dr. Kressley, for a wonderful presentation. We do have a couple of questions that have come in, but before we do that, I just want to remind everyone that by the end of the week, all of the attendees of today's live webinar will receive an email, and that will have a copy of the presentation. It will have the presentation recording and your CEU certificate. If you are interested in hearing more about Office Practicum, who's sponsoring today's webinar, and actually see the OP platform pediatric tools in action, stay on the line for a quick overview and product demonstration. And finally, when you close out of today's event, you'll receive a brief survey. Please take a minute to provide your feedback here. As part of this survey, you'll also be able to request follow-up from an Office Practicum representative regarding OP's products and services, if you so desire. Now we'll go ahead and hop right into our questions. And Dr. Kressley, here's the first one. Says we are fairly proactive in following up on referrals. Sometimes we never hear back from the patient or the specialist. How long do you recommend leaving a referral open?
So I think it depends on the reason for the referral. And again, that has to do with the criticality. If it's the patient with acne and you didn't do it, just document, made 3 attempts to try to close this referral loop and closing it because we could not verify. And then you may even want to make a note on the chart or a pop-up alert that says next time patient is in, find out what happened, so that you at least have a different way to do that, or send them a portal message. If it's something critical, I think that you keep calling the patient and reaching out. Start by phone messages, portal messages, and if need be, send a certified letter saying that we're very concerned that we sent you for this problem and we want to make sure that you're okay. So I really think it depends on the acuity, and try to make it as the least subjective as possible. And you may decide that, you know, certain age groups or certain specialty referrals you handle one way, and others you handle a different way. But again, if there's a way to mark that when you make the referral, the ordering clinician should be the one to make that determination.
Wonderful. Thank you. The next question is around tracking. How do you track the specialist contact for follow-up from phone to fax to letter?
So I think the question is how my office staff would track that. We would make a little note in the referral that says faxed request for letter on this day, follow up on this day, and we'd change the sort of the task required by the referral tracking team. And so that there is with each referral sort of comments. And if you don't have the ability to do that in the referral itself, at least in the message center or something notating in the chart, that's really important for medical legal reasons. You are in a much better situation if somebody looks at your medical records and can say, I reached out to the specialist these 3 times, I reached out to the parents these 3 times, than if it's just not documented. Keeping track of in your address book, all the specialty contact numbers, etc., is a daunting task, but an important one. And I would argue that at least yearly, your team should sit down and have a cleanup project of, do we still use these specialists? Are they still important? And maybe you track the name of the specialty group, not the doctors themselves, because there's so much variability, and that will depend on your medical home neighborhood and your specialist access.
Thank you. Next question is, can you please share the 3 steps for getting reports from specialists? Did you mention that during your presentation?
Yeah. So I think the questioner is asking about my graduated pressure on specialists to send information, and we'll see with with the team care. I'll work with your team to see if we can get those sample letters out to people if possible. The first letter really it's a fax letter that I sent that says, we saw, we referred this patient with this date of birth on this date. As part of our responsibility and shared caring for patients as a specialist, you are required to send me a report for care every time you see this patient. Please fax it to this number. Call us if there's a problem. If you'd like to know how to get it to us via direct messaging and on CDAs, we can accept those too. Please contact us. We'll expect to hear from you within 7 calendar days. If we don't, expect to hear from my NOGI team again. The second one really says the same thing and just says we've already made a couple attempts to reach out to you. We haven't had a response. We are concerned that clinical care will be impacted because you did not provide us with the appropriate information in order to provide the best care for this patient, which medical legally sort of is scary to some of them, and they respond to that one. And the third letter, which often gets more traction because that's the one that goes to the doctors, says we are going to change our referral patterns, and unless you can find a way to get us information in a timely way, we will be looking alternatives to refer our patients to other specialists unless we can rectify this problem together.
Great, thank you. You mentioned considering using a marker to track critical referrals. Do you have any suggestions on a marker?
So some technology allows you to do it. Some people just write in in the note urgent referral. There's other ways that you can do it. Some people to put a pop-up alert somewhere, and some people have a separate way that they just send a message to the referral clerk saying, this is an urgent referral. Make sure that you keep an eye on it in a different way. I would say use whatever process, technology, and people you have. First, determine what your practice is going to say is a critical referral, but there should be a way for you to make sure that happens. It doesn't happen often, but you don't want those critical referrals to get lost in the routine referrals, if you will.
Okay, great. Next question is, how can a small pediatric practice compete with big organizations that have their own medical home and network and all the convenient access to labs, radiology, and more for patients, thus making it easier to track?
You're talking to somebody who started a solo practice, so I think there are ways to compete, and we have better value. We can prove our value to patients and families. You're going to have less volume, but you also can provide it at higher value and lower cost. And so, Carrie, I think we just may have made ourselves a topic for a different webinar for a different day. Simplify your processes. You're going to have a team that should be cross-trained so everybody really understands everything and you have less handoffs, but you should still be able to make that happen. And the 21st Century Cures Act says that big health systems or big health vendors can no longer block from giving you as a primary care medical home access to information that's critical for you to coordinate the care for patients. So if you have a health system that won't send you referrals back or won't connect via direct messaging, that could be considered information blocking, and I'd be happy to talk with you about it more offline.
Thank you, and I agree with you. That would be a great topic for another webinar. We are quickly approaching the top of the hour, so this is going to have to be our last question. And the question is, what if we can't get providers to agree to cover the labs for the provider that's out on vacation?
Start with your medical malpractice carrier and pose that question to them and ask them if they'd be willing to entertain an educational series where they would bring an expert in and talk to your providers about how they are putting each other at medical liability risk if they don't find a way to timely refer and cover each other on vacation. That's a great way to impress upon themselves that they're putting the whole practice team and patients at risk if they don't come to an agreement about that. That would be my suggestion. Wonderful.
Thank you so much for sharing your time and expertise with us, and wanted to thank everyone else for attending today's webinar. As I mentioned before, if you are interested in hearing more about Office Practicum and actually seeing the OP platform and some of the tools that we have, stay on the line for a quick overview and product demonstration of the tools that Dr. Kressley referred to. All right, and with that, I'm going to change the presentation over to our senior engineer, Susan Hanna.
Thank you, everyone, and thank you, Dr. Kressley, for showing us and giving us all this information. We know that both our practices, our existing practices, as well as our those from our broader pediatric community who are on the line are going to benefit from all of this. So whether you've been an OP customer for 35 years or only just hearing about us, we hope you have a few more minutes so that we can show you the tools that OP has that give value to our practices to be able to exercise the techniques and the tools that Dr. Kressley just showed us. Our electronic health records, practice management system, billing services, and business analytics tools help pediatric practices improve clinical and financial outcomes. So as we go through, OP, our mission is improving healthcare through technology. And so we're going to look at three key items here. The first is direct messaging. We talked about that a little bit on the webinar. And just as a reminder, it is integrated into Office Practicum. It is a HIPAA-compliant email network that allows you to communicate and transmit PHI to those specialists, as well as receive CDAs and information back directly into OP. The ability to do that within your EHR really does have a positive impact on your patient care.
Hey, Susan, this is Sue Kressley. I'm not seeing your presentation slides.
Oh, okay, thank you.
Yep.
And now, Sue?
I'm seeing eLab overview. Thank
Perfect.
you.
Yep, thank you very much. All right, so the next item is our diagnostic test, so our eLabs. So a couple things as a reminder for our practices. When you submit and create that eLab and send that electronic requisition out to Quest or LabCorp or your local lab, there's a couple things that you can do in there. The first is that flag date, so that expectation of the return. So when Dr. Kressley talked about how do we manage these and when we think they're going to be able to come back, that's that first tool, is that flag date. The second thing, which is a reminder, we know that we have kids that go out for labs, and we may not want everyone within our practice, or frankly, team privacy issues, not having things posted on our patient portal. So reminder that those privacy levels are there for you, and they have 4 different levels that you can set as well. The other thing about our diagnostic test is that auto matching, so that when we think about receiving those results in, they're going to come directly back into Office Practicum. So what I'm going to do real briefly here is I'm going to jump back out and I'm going to look at these items within OP. So the one that we spent a lot of time on is referrals. So when we think about our kiddos and how we create that referral within our system, whether you send this as a task to your care coordinator, your clinical nurse managers, your front desk, or you do it yourself, either way, you're going to start within your referral or transition to care detail. We're going to refer out to our specialist, and we talked about having a repository for specialists. So if you are managing your address book in OP, I can go in here and say, I want to send my kiddo to the ENT. What that brings up is all of my ENTs that I am actively referring to. So I'm simply going to select one. And here we just simply are starting that whole process. I can go in and say why I'm sending my kiddo out. So my kiddo is being sent out for recurrent otitis media. Something very simple. Now, notice that Office Practicum has that flag date. Our auto flag date is 2 weeks. But depending on when you know that the specialist allows you to get appointments or allows the parents to get appointments, or if this is one of those critical items, you have the ability to manage those flags here directly within Office Practicum. The other thing that you can do, and this goes to one of the questions that had come up, which is how do you keep those notes within OP? Mom called and said, she has an appointment on August 1st. You simply have the ability to add internal notes here within the system. Now we have a couple different options, and you can use multiple options. Send would be if we were going to send this through our direct messaging. So I can send this out to my specialist. As Dr. Kressley mentioned, we may want to give this to our parents so that the parent shows up at the specialist with the information. So I can also print. This information is going to be a full transition of care. So it's going to have the letter with your reason for the referral. It's going to have your problem list, your active medications, their demographics, their insurance information. So now your specialist has all of the information they need in order to be able to see our kiddo. But we also want to think about, so that's you or your team creating those referrals, but how do we then manage those referrals? We do it here within our clinical workflow. So when I think about my referrals here is the referral I just made for my kiddo, Valeria. But when I look at how I manage those, my care coordination team can simply look at all of the referrals and those flag dates. As we think about those appointments, those notes that we put in, again, we can manage these items as we need to, simply changing flag dates based on when we know that we expect that letter in. When we get our response in for the specialist, just as a reminder, it will be attached to this requisition and will be marked as completed. So we can manage these items as well. The other part is when we think about closing the loop on our diagnostic tests, same concept here, you're going to be able to manage your diagnostic test requisitions. You're going to be able to manage your flag dates as well as your privacy levels. So the ability to work through and manage by your care coordination team, your diagnostic tests, your referrals are all within one worksheet for your team to handle. The other thing for our OP practices, Dr. Kressley talked about cleaning the slate. So don't forget, we have an archive tool within OP. So if this is something that's going to be new for you to implement within your practice, you are going to be able to work through archiving those prior or old items. So you do have that clean slate. Don't let the old data be the hindrance for you actually moving forward. And with that, we just want to thank once again Dr. Kressley for sharing her time and wisdom with all of us. If a member of the OP team can be of assistance for you, if you are an OP customer on anything that you saw today, make sure to fill out the request at the end, and we'll have a member of our account management team follow up with you. If you aren't an OP customer and would piqued your interest enough to learn more about OP for the first time, please be sure to check yes in the webinar survey, and we'll have a member of our business development team reach out to you to personalize the demonstration for you. And my final reminder is, if you have not already done so, please remember to register for part 2 of improving clinical and financial outcomes, which we will be offering next month. So once again, thank you very much and have a great day.